but this came out in April. So this is the DanGer shock trial. So a lot of big words, and microaxial flow pump or standard care for infarct-related cardiogenic shock. Essentially, they're looking at the use of Impella devices. So the background, cardiogenic shock was first coined by Harrison in the late 30s, which differentiated from other forms of shock. And acute MI is the most common cause of cardiogenic shock, and it has had a pretty significant mortality up to approximately 50%, which has somewhat changed in the last 20 years or so. So as far as mortality and randomized controlled trials, the first positive trial was in 1999, was the shock trial, which did have a mortality benefit at 6 months, but not at 30 days in patients undergoing early revascularization. Looking back through previous studies, one of the most, or the biggest issues in performing and also comparing these trials is that there really hadn't been a standardized definition of what cardiogenic shock was. A lot of them are derived from the European Society of Cardiology, the shock trial, IVP2 shock trial, and the culprit shock trial. In 2019, though, a lot of this changed since the SCI classification was developed for cardiogenic shock. So here you see the SCI classification, A, B, C, D, E, and just increasing levels of, I guess, how sick the patient truly is. C is probably one of the more common ones that we get involved in, where the patients do have evidence of hypoperfusion. We're resuscitating them, they're on pressors, but they continue to, have this hypotension or persistent lactic acidosis, and then we go looking for, cardiogenic shock as an etiology. So as far as the background leading up to this trial too, is cardiogenic shock, like I had said before, it is a frequent complication of patients, particularly presenting with STEMIs. It does carry a pretty significant morbidity and mortality. It occurs in approximately 8 to 10% of patients presenting with STEMI. And STEMI-related cardiogenic shock also, like I said before, carries about a 40 to 50% overall mortality. Microaxial flow pumps. So they are percutaneously inserted devices. Some involve a cut down grab. And there's a slide coming out that kind of walks through these Impella devices as well. But the whole idea being is that they unload the left ventricle and they pump blood into the ascending aorta, reducing their overall diastolic volume, reducing overall cardiac work and myocardial O2 consumption. So there have been trials looking at this. Three previous trials, they were small. They didn't really demonstrate a significant clinical benefit, particularly in AMI-related cardiogenic shock, and also indicated some adverse events, including bleeding, et cetera. So looking here, I've seen a couple C questions where I've gotten asked about this IVP shock 2 trial, looking at third day all-cause mortality with balloon pumps and comparing them to the standard care, and really had no significant mortality benefit. The ISAR shock trial did compare the balloon pumps versus Impella. Also, no difference in 30-day mortality, but did have improved cardiac index in the Impella arm. This is just a diagram of kind of walking through, because I know we occasionally rotate through the CDICU, but understanding how the setup really is. So you have the automated kind of controller runs through the percutaneous device, the Impella gets inserted and kind of run up. The catheter itself, if you look in the figure A at the bottom, is basically how the actual catheter itself is kind of set up, wedging through the aortic valve into the OB and then out into the aorta. So the percutaneous ones on the left side, so you have the Impella 2.5, the CP, and RP, those can be placed percutaneously, and they're arranged in increasing order of how much flow support they can provide, also size as well, and then the other two requiring surgical cut downs. That brings us to this trial. It was published in April of this year. Basically, just looking at implementation of these devices in addition to the standard care, comparing that to without these flow pumps at all. That brings a question. Does the routine use of these flow pumps, in addition to standard guideline-directed therapies in patients with STEMI-related cardiogenic shock, lower mortality of any cause at day 180? So the way the study was designed, it was an open label, international multi-center randomized controlled trial. It was unblinded, but it was conducted in approximately 14 centers in Denmark, Germany, one in the UK. Patients were assigned to receive either the microaxial flow pump, which was an Impella CP plus standard care versus standard care alone. And that included, whether or not the patient needed to be intubated, various vasopressors, or inotropic therapy. And so how these patients were randomized, so they used a web-based system stratified by timing relative to revascularization, but also the localization of where the STEMI was, either anterior or non-anterior. So when they performed the randomization, it occurred in the cath lab, either before or after revascularization, but could also occur up to 12 hours after revascularization, depending on whenever they actually recognized that cardiogenic shock was present. So inclusion criteria, those patients 18 years or older, they had STEMI or STEMI equivalents with associated cardiogenic shock. And then the cardiogenic shock was less than 24 hours, but it was confirmed by persistent hypotension with a systolic less than 100 plus or minus the needed base of support. They had evidence of end organ hypoperfusion with a lactic acid of greater than or equal to 2.5 or an SpO2 less than 55 with a normal PaO2, and also their EF less than 45%. Exclusion criteria. So anybody that was like resuscitated from an out-of-hospital cardiac arrest with a persistent GCS less than 80, people that had shock duration greater than 24 hours, severe RV failure, severe AR or stenosis, any severe peripheral arterial disease that would preclude placement of these peripheral devices, any other forms of shock, so sepsis, neurogenic, anything like that, or people that had a mechanical complication of MI, or patients with a life expectancy of less than 1 year due to underlying comorbidities. So they screened about 1,200 patients. And the process recruitment went from like 2013 all the way to about 2019, 2021, I believe. They actually randomized 360 of those patients, and then consent was withdrawn from about 5 of them. So overall, it's about 355 patients overall, I believe, that underwent the study. Overall, the study's the baseline characteristics, it was pretty well balanced. However, it did favor males, particularly in the age range of like 60 to 65-ish. That's about it. Most of them had either grade C, sky stage C, cardiogenic shock or above. And then most of them had multi-vessel disease as well. As far as the protocol is concerned, so both groups underwent revascularization with primary PCI, particularly as they're presenting with STEMI. The standard of care group, basically, they were allowed to use vasopressors, inotropic therapy, and could be intubated as they needed. And then the patients in the other arm, the microaxial flow pump was either placed immediately after the procedure. Some, I think, were placed before. And basically what they did was they ran them at the highest performance level for 48 hours after placement, unless there were some complications that had occurred. If that wasn't enough support, both arms could be escalated with additional mechanical support if they were persistently like hemodynamically unstable, not perfusing, et cetera. In the flow pump arm, they could be escalated to a larger Impella first. And then kind of step up from there, including VA ECMO. And then in the control group, the first step was VA ECMO, but they could consider stepping up to a larger sized Impella. In the study, they were looking at the Impella CP specifically. And so if they decided to use an Impella CP for the control group, then they define that as a protocol violation. In the flow pump arm, 16% of patients required escalation of therapy, and then 21% in the standard group, and mainly up to VA. And then the other piece of it is what maintained the standardization is that the hemodynamic criteria and specific guidelines on how to wean the Impella itself was provided to these centers. So what they looked at, the primary endpoint was death from any cause at 180 days. And then the secondary endpoints were their composite cardiac endpoint, which included escalation to additional mechanical support, heart transplantation, or death. And then also number of days alive and out of the hospital at negative 180. They were also looking at various adverse events, so moderate to severe bleeding, limb ischemia, stroke, use or requirement of renal replacement therapy, sepsis with positive blood cultures, and then the pretty much continued that across the composite safety endpoint. But they were also looking at hemolysis, device failure, worsening cardiac regurgitation. So your in-hospital management, looking at the patients that got the mechanical support, particularly in the axial flow pump device, there was some hemolysis that was noted on their labs, about 12.4% of those patients. But overall, low device malfunction, and the majority of these patients were successfully weaned off of these microaxial flow pumps. Very little overall escalation, and if they were, a lot of these patients were escalated to VA ECMO. Yeah.
So if the patient was escalated to ECMO, were they taken out of stats? How would they?
They were included.
They were still included.
Yeah.
I'm talking about like the 29 to 16%. So maybe that includes those and get a good outcome of that outcome.
Like 11 compared to 18% needed escalation.
And then this one, what I took away from this is patients that were undergoing like in-hospital stage PCI, typically if they were on the top, they were in the hospital longer. So these are the results of the primary endpoint. So the number needed to treat was about 8. And overall, the death from any cause at 180 days was about 45% or 46% to about 59% in the standard care arm with a hazard ratio of 0.74. They did have a 95% confidence interval, 0.55 to 0.99. So fairly good. As we're moving on here, as they went to like the forest plot and look at the secondaries as well, particularly where this was more beneficial were males hypotensive and their MAPs being less than 64, and then those with, greater than 2 disease vessels. Composite cardiac endpoint. So also their hazard ratio is 0.72. And then the number of days alive and out of the hospital at day 180 was also improved as well compared to the standard care arm. The caveat here, which I found that this study was pretty interesting, is that they also went with these pumps in place, there were significant adverse events. So from the composite safety endpoint, that had a risk ratio of 4.74. Moderate to severe bleeding was higher, limb ischemia higher, renal replacement therapy also higher. The idea being is that they were running these pumps for 48 hours at the highest settings, could have induced hemolysis and breeding blood leading to, AKI and needed for renal replacement therapy. Also increased risk of sepsis and bacteremia. So actually, the number needed to harm from this trial was about 6. But going back to the overall primary endpoint, including those risks, the overall mortality still had a mortality benefit. So as far as the trial is concerned, the trial was unblinded. Biomed is the manufacturer for Impella. They were involved. They did fund portions of the study. I think overall the patient population, there was poor representation of race and gender here. This was primarily males. I believe the study had like 70% that were men. There wasn't really any standardization for the standard of care as far as like protocols or anything like that. It was really just you're allowed to kind of use what's pressor or inotrope. It's really up to the provider's discretion. And then also just running the highest support or the highest flow on these Impellas wasn't causing hemolysis, leading to risk of AKI, need for renal replacement therapy. So overall, I think this is a pretty sick cohort, and then they did a really good job balancing out both arms. There were minimal protocol violations. They did provide guidelines specifically for weaning of these mechanical support devices. And it, from our side of things, it has a mortality benefit, which we don't always get, but so pretty good. So I think overall, they do have mortality benefit. I think anecdotally, for those that rotated through CVICU and things, we certainly have seen pretty significant complications from, peripherally inserted devices. But, looking at it, the overall mortality benefit with these adverse events, could we look into ways to mitigate the risk of these adverse effects and potentially, improve mortality, or given that a lot of these, adverse events could significantly contribute to mortality in a setting, right? So I think looking into how we mitigate complications from these could have even more of a significant benefit.
Yeah, very
slide with the number needs of firm.
And it's crazy that this was positive compared to like the IVP shock versus and the ECLS shock, like the VA mode and
So in the
could read about comparing this group to those groups.
So they were actually looking at, because what they were saying was because they picked 180 days for a reason, I guess, to extend this mortality benefit out. And they were looking back at the data and saying, well, the IVP trial was only at 30 days and not 180. And would there not be a benefit at 30, but potentially at 180 days? Would that benefit actually come through?
I think there was a meta-analysis looking at the ECMO and this population also showed 30-day made no difference, but 20-day also had something to do.
Yeah.
So that's interesting. Also, I think they have a little bit stricter neurological incomes. They picked patients that are going to had a higher chance to overcome.
Yeah.
Compared to them. So it's pretty good study.
And did most of these patients that did receive the microaxial mount get the CAP like at the same time, or did they do like the?
So some were input before, I think, prior to CAP.
Okay.
And then also like they were in shock post CAP. Sorry, I think the trial was looking at placing the impellant first and then going for CAP.
That's their running thought, is if it is left main, like we do that a lot for high risk PCI here, actually, is we pre-place Impella CPs to support the LV in case they go through VT, VFib, or they have low flow to the left main whenever they're stenting, right, or dissection or whatever, that they'll have some support during it. And so the thought is you don't know which vessel is, and to your point, that's probably why they did anterior MIs versus, right, because anterior MIs going to be more so left main associated.
Yeah.
So with that, I would think that there would be a higher benefit for placing your Impella CPs prior to anterior MIs, right, to your guys' point. So I don't know if there's any doing recovery.
Yeah. Nice.
The other thing too that I wish they had commented more on is they actually did have a lot of hemolysis. And I mean, when I manage this up there, there's a specific like algorithm for whenever you start getting hemolysis, right?
Yeah,
So you
that titrated.
well, it's not only that, right? There's multiple different causes for it. So it could be Impella malpositioning, right? So you ultrasound your Impella, you see where it's positioned, make sure it's in the right spot, right? Then the next part is yes, your flows may be too high, right? And so you could try down titrating your flow, seeing if the cardiac index or if you still have enough support with the down titrated flow, because sometimes you're pulling so hard that you're just equalizing and you get the same flows at P5 versus P6. And then lastly, after that, sometimes too, it depends on what the patient afterload is too, or preload is, right? So if you're trying to have them push against an insane afterload and the motor's going like crazy, right? You may have to afterload them. So I wish they had commented more on that. Again, like I'm just wondering if they started looking at more so protocolized management of hemolysis, if they would have less. So.
Is there any follow-up on those patients that develop those complications, even though they survive from their symptoms or deficits or anything like that?
They didn't have renal recovery.
Yeah, because I mean,
I didn't see.
yeah, there's mortality benefit, but I mean, this was which countries? UK?
Yeah.
Denmark.
And then they have increased ICU length of stay, so cost, I think, is also an issue at least in the US.
Yeah.
try to apply that with how much it costs to put the device in ICU and sustain it, rehab and all that. I mean, those countries probably it's either free.
Well, that would be one of my questions to you. Like overall cost.
They do online, but at what cost?
Yeah.
Yeah.
Or like you were mentioning too, is what is their neurologic outcome that they're basing this to? Was there still some deficits, right? Like,